right, Dr. Weinstock, welcome. I've got your book. We have famous Dr. Michael Weinstock with us to talk on a whole bunch of things that I'm very curious to hear about. So welcome, and I appreciate you willing to come on with us.
Well, thanks so much. It's an honor to be here. And yeah, these are my passion subjects to talk about. So really looking forward to it.
All right, Joel, if you don't mind, I hope, one of the things that I wanted to ask first off is like, how in the world did you get into this particular niche?
Yeah.
Yeah, this is something that we were joking a little bit earlier about. Your name is a voice in the back of our head every time we're discharging a patient. So how'd you fall into this?
So the funny part is about 25 years ago, which is sort of crazy and scary, it was me and two of my partners in my family room talking about cases. And we sort of started with like an M&M type of format. But the ones that really interested me were the ones that were discharged and then returned for a different reason. And we, through the years, with this conference, which we started doing and got bigger and bigger and bigger, and eventually moved to a restaurant, then a bigger restaurant, then became the biggest conference in the Mount Carmel system, which is in Columbus, Ohio. And we had, hundreds of people come to these conferences eventually, but we developed quite a few cases. And someone said, hey, look, you should put this into a book format because it really benefit other folks. And so I contacted Greg Henry. He was the past president of ACEPT and unfortunately passed away just a couple of years ago. But he was a huge voice in medical legal and in physician and clinician advocacy within emergency medicine. And I didn't hear anything back. And I reached out again. I said, look, here's my idea. I'm going to send you the case, but not tell you what happened. And I want you to sort of like have some commentary and ratings on it. Didn't hear back. And so I eventually called him and he answered the phone and he's like, what do you want? In a true Greg Henry fashion. I told him, he says, it sounds like a pretty good idea. And what started as one book in 2006 now has grown. We have 4 different books. We have the classic Bounce Backs. We have Bounce Backs Medical and Legal, Bounce Backs Pediatrics, and then Bounce Backs Critical Care, which came out a few years ago.
Well, 2006, we all have these cases that really made, strong imprints on us. So around that same time that you're coming out with the book, one of the patients that I remember very vividly in my head is a gentleman who was walking in his backyard and was barefoot and stepped on a little stump, small little stump. And he came in and he's like, my foot's really hurting. And so I'm like, all right. So I take a look, normal exam, normal vital signs, nothing out of the ordinary. I x-ray his foot and he's got this big bone spur right where he's hurting. So no risk factors, nothing else. So I'm like, all right, here's some pain medicine and, follow-up arranged, whatever. He comes back about 6 hours later. My foot's killing me. So I'm off shift. There's another doctor that's taking care of him. And he's like, wow, this is pretty worrisome. This seems more painful than it should be. Let me get some blood work. Let's get some, repeat x-rays, looking for gas in the tissue. Does all this stuff. And, so necrotizing fasciitis is on the radar. Basically comes up with nothing, no redness, nothing to track. And discharge comes back about 6 hours later, full septic shock, massive necrotizing fasciitis coming up to the hip. And I've played that over and over in our heads and we've talked about it. So, what are these cases that come back that teach us something that we don't get on the first round?
So one thing that is really important to talk about just up front is that just because a patient bounces back does not mean that something wrong was done.
Mm-hmm.
And it's really important that we think about that in the sense that, and I'm going to throw out a bunch of numbers here, but during the course of our 30 or 40 year emergency medicine career, we will see 150 to 200,000 patients. Now, in 2007, David Sklar published a study in Annals of Emergency Medicine where they looked at patients who bounced back and died within 1 week. And they looked at 387,000 patients, and they found of the possible error cases of the ones who died within a week, that was 35 of those cases. So 1 in 11,000 patients. Well, if you do those numbers, each of us during the course of our career will send home 17 patients, which sounds like a lot, but it's really 1 every 2 years. So you're 99.99% not sending those patients home, but we will send home 17 patients who will die, potentially avoidable death, within 1 week of the ED discharge. Now, that is, those are the patients that Sklar thought maybe were error cases. Well, when you think of all of the patients that we see, somewhere between 3 and 8% bounce back. So I'm not going to throw out any more numbers right now. We'll sort of digest all those that I just put out. But in the end, we want patients to return who are having potentially a progression of their symptoms, changed symptoms, worse or unresolved symptoms. And we want to make sure, and I'm going to give an example of that in just a little bit here, but it was either Amal Mattu or Steve Clucciello from Carolinas who said, look, this is our last chance to get it right on discharge. So the last thing I just wanted to talk about with this, and then we can expand on it, of course, is one approach that I advocate, and we can maybe have this as one of the very first big teaching points of this discussion here, is doing a hard stop in your MDM, in your medical decision-making. And what I mean by that is before you discharge a patient, ask yourself if this patient does bounce back, and in a bad way, horizontal and room temperature, right? Dead. What could I potentially have missed? And that's what I call a hard stop, to say, what are those things that could happen? Because, if you go into an M&M conference, I'm not saying it's easy to guess the diagnosis, but oftentimes you could say, okay, if they had chest pain, it's going to be ACSPE or dissection. I guess it could be pericardial tamponade, tension pneumothorax, or Boerhaave, but usually you're going to get those based on your exam or some of the testing that you do. But in the end, ACSPE and dissection, what have I done to make sure those things aren't going on? And if I can't even convince myself when I'm writing my MDM note, well, there's no way that I can convince a parent or a spouse or a department chair or a jury. And sometimes that act of doing that hard stop, considering what bad could be going on and how I've accounted for that, can be the thing that prompts us, not necessarily with more testing, but more data gathering. Second big sort of teaching point here, a phrase that I use very commonly, and folks have probably heard me say this on MRAP, a good history is free, but a poor history can be expensive. And I will give Kevin Clower the credit for the second half of that expression. But in the end, right, we're sitting at the bedside. We can get all the information that we want. We are the historian. We are the documentarian. We are the investigative reporter. A patient might not be able to give a good history, but there's no bad patient historians. We are the historian. So sort of a little bit longer answer, went some different ways, short question, long answer. But in the end, the big themes are, just because a patient bounces back doesn't mean something was wrong was done. We want patients to bounce back when they have progression of their symptoms, but in the end, maybe doing that hard stop before a patient leaves would prevent a adverse outcome occurring before they have the chance to bounce back.
Mm-hmm. I love that you mentioned that about, just because they bounced back doesn't mean something was done wrong. I remember the first time I was an intern, and this was at County Hospital down at in Maricopa here. And we had a bounce back, and of course all the residents are groaning, like, oh, this guy's back, and I had not seen him, and I was early in my intern year, and an attending was like, well, I'll just pick him up and go see what the issue is. So he walks in the room, and his opening line is, hey, I'm glad to see that you came back, because I'm glad that you trust our care, and we want to make sure we figure this out. Let's dive into this and see if things are progressing, or could something we do better. And I remember being so impressed with that, because at the doctor's station, the overall vibe was like, oh, like, here's this guy we just discharged yesterday. What's he doing back again? And that attending, he was like, no, this is a chance for us to see, was something missed? Did something escalate here? Is something progressing? that we didn't like with Eric's case. You know, you're not going to catch that on that first time. And so I remember being so impressed with that. And after I we left the room, I said that was an awesome way to interact with that patient, because the patient actually said, yeah, the doctor I saw yesterday was great, and this is different now today, and I thought I'd better come back and get checked. And he listened so well that I thought, I'm going to come back here. And I said, where did you, like, where would someone learn this kind of stuff? And he goes, look up Weinstock. And I remember writing your name down in my little pocket thing, because he said, you know, he's kind of a leader in this, not only bounce back from a medical mindset, but also how to interact with the patient, how to make a bounce back not a bad thing for either patient or provider. And I think that's what's really interesting about it, you know, because I think a lot of times we do think of a bounce back as a failure of some kind.
So I've heard some of the shoulders that I stand on talk about, you know, that same type of terminology, you know, thanks for the opportunity to reevaluate you. And I do a lot of residency lectures around the country. I love doing those lectures. And what I'll say to the residents is, listen, I can guarantee you in your career, again, of those 150 to 200,000 patients, I can guarantee you, you will see a patient with vomiting and diarrhea who has minimal generalized abdominal cramping, who the next day will turn out to have appendicitis. You should not have scanned that patient for appendicitis with that initial visit. You're going to do more harm than good. But exactly like you're saying, Joel, is to make sure that you inform the patient on diagnostic uncertainty when that remains. So is it okay if I tell a story, a quick case that is just really a great example of this? So this is the first case in the second bounce backs book in the medical legal. And Alma Matu and I actually, no, that's not true. Swami and I actually discussed this last year, so 2025 in July, in the first month episode. So I do a risk management segment the first week of each month for MRAP, and that started just in July of 2025. But I told this story about Anna, 39-year-old woman who got bronchitis every year, right? You know, so she goes to primary care in September, gets a Z-Pack, goes into the ER, and she gets actually two Z-Packs for what they thought was acute bronchitis. But in the end, what happened is it wasn't adequate data gathering. She presented, the chief complaint as described by the physician was chest pain. They didn't really evaluate adequately based on their data gathering. The history is free, right? For ACS PE dissection. When she went home, she could have had any of those things. And I will say, and I just had an article published for a study that I designed and worked with a lot of really great national researchers. American Journal of Emergency Medicine just came out a couple of months ago. The prevalence of life-threatening diagnoses in emergency department patients with chest pain in a national group. We looked at almost 1 million patients, and what we found was that, I mean, 1 million chest pain patients, I should say, is 14 million almost total patients, but about 6 or 7% of our ED patients are chest pain. Well, anyways, short version is that of those diagnoses, about 17 out of 18 patients will not have one of those life-threatening diagnoses. So if you think of ACS, about 1 in 20 of our chest pain patients, PE about 1 in 100, and dissection about 1 in 1,000. So you can play the odds with Anna, 39-year-old woman who has a cough, who has some reproducible chest wall pain. But her chief complaint was not productive cough and a fever. Her chief complaint was chest pain when she presented at the ED and was triaged just after 5 o'clock in the morning. So the short version of this story is that the expression, there are old pilots and there are bold pilots, but there are no old, bold pilots. In other words, you can play the odds and be right for any specific patient, but through the course of a career where you will see about 10,000 or 12,000 chest pain patients during the course of your career, you cannot play the odds for the 1 in 1,000 and be right for 10,000 patients, right? So what happens with Anna, she's discharged home. Her husband gets home from work later. How you feeling? Oh, not really better. The antibiotics haven't kicked in yet. But here's the part that really blows my mind. She walks into the kitchen after dinner, falls to the ground, water glass crashing to the floor. Her husband and 3 sons rush in to find her unresponsive on the floor. Head spin with this next part. Her husband calls EMS, and I have the actual document of EMS on my computer, calls EMS and says, My wife is unresponsive. I think she choked on a piece of chicken. This is the morning that morning she went to the ED with chest pain. She collapses that night, and he is so reassured that this wasn't from ACS, PE, or dissection that he thought she'd choked on a piece of chicken. And in the end, they get there, the paramedics. He tells her the same story. I think she choked on a piece of chicken. She's in VFib. They shock her, intubate, take her to the ER, unable to resuscitate. And in the end, the day later, autopsy shows a complete occlusion of the LAD. She died of an MI. And the data that was not gathered appropriately was the fact that she did have exertional chest discomfort. There were other parts of that history that would have actually helped, as well as the fact, family history, her brother died of an autopsy-proven MI at the age of 35. She was 39. So short version with all of this, again, short statement, long answer, but I think it's just a great way to demonstrate how important it is that the patient understands when that diagnostic uncertainty remains upon discharge, because that really truly is our last chance to get it right. That's the chance for them to return and give us that second chance.
Yeah. You know, when I was at county, they played a game. I don't know. I wonder if this is a nationwide game or if this was just us, but the game was called You Wake Up Dead, and it was based on your book. So they would pull a case out and they would say, like this case, chest pain, bronchitis, gets a Z-Pack, wakes up dead. What did you miss? And it was this anxiety provoking game. But one thing that we learned playing that game was, I remember my very first one was a guy with flank pain, blood in his urine, right? That classic, oh, it's got to be a kidney stone, ends up being a AAA. But one thing I learned about that was the danger of locking on to a diagnosis early, even if the patient hands it to you on a silver platter. I always get bronchitis like this every year. All I need is a Z-Pack. I'm out of here, doc. Don't worry about it. But that is not our job. Our job is to step back and say, what else could this be? And you're right. You've got those odds. You can play those odds and you'll be right so often that it can lull you into this kind of sleepy hip shot diagnosis. And I see that sometimes and it makes me worry. I see that in myself, and I have to correct myself a lot of times to where I'll say, wait a minute. As I'm typing out my MDM, what could this be?
Well, and going to the aviation side, they talk about, you take off over max weight and everything's fine. And so you shift your position from being conservative to a little bit more lax, and then you do it again and it moves that further and further away. So you and then the Swiss cheese starts to happen. So
yeah.
You're talking about chest pain, and I remember, way back in the day, early in residency, if you had chest pain, you got admitted. Like it was, you didn't even think about it, and they got the 3 sets of enzymes over 24 hours or whatever. Obviously we approach it way differently now than we did back in the, mid 90s. Have we gotten better as a specialty? And one of the problems that Amal Mattu gave a lecture at ACEP last year, and he talked about how you can't trust any of the history. That you could have, I took Pepto-Bismol, I got better, it's an MI, or I've got a little shoulder pain, it's an MI. Like he just scared the pants off of me. But anyways, are we better today than we used to be?
So a couple of thoughts. The first is Pat Crosscarry, the Canadian emergency physician, who came up with a lot of these CDRs, these cognitive dispositions to respond, as you were talking about, Joel, that anchoring bias. And we have to be very cautious when a patient tells us the diagnosis. So Jonathan Larson, who wrote the musical Rent, which was like the biggest musical in the history of Broadway, he went into 2 New York EDs the first time saying, I ate a bad turkey sandwich. He told them the diagnosis that he thought he had. He went into and he was diagnosed with food poisoning. The second time, he, about a day and a half later, was diagnosed with viral gastroenteritis, of course. And unfortunately, after preview night of the musical, where the New York Times writer who went to see preview night said, this is going to be the greatest musical in the history of theater, he was found dead in his apartment from a aortic dissection and cardiac tamponade from that. And in the end, we need to really understand our role as, again, that historian, documentarian, as the investigative reporter, and make sure that we don't let a patient talk us into a more benign diagnosis. The second thing, and Eric, you were sort of talking about this just a little bit ago, is very important as far as an airline pilot, right? Or the weight limit. But a lot of times we are compared to that. Well, airline pilots have objective data. This is a gauge. It is a needle pointing to your altitude, to how much fuel you have, right? Well, in the end, we are dealing with patients, the human condition, right? We have pre-verbal patients. We have patients who have an inability to tell us their history because of dementia, or maybe because they just don't have the vocabulary to be able to do that. So that's the biggest part of things. Now, when Amal talks about the fact, and he wrote a really nice article on this, that the history is not really necessarily helpful. And I do want to talk about this because that's one of my biggest research interests, which is chest pain. So in 2015, I published a study in JAMA IM, and actually Scott Weingart was one of the co-authors on the study, but we found 49.7%, I think, were the number of patients that got admitted with chest pain. We're better now. We're better now for several reasons. One, because of Barbara Bacchus with her 2013 study, International Journal of Cardiology, where she actually, with the heart score, told us we could send home low-risk patients. Published multiple studies with moderate risk heart score patients showing that an expedited outpatient evaluation can be the same as the admission of a patient as far as patient safety and mortality, and actually presented some of that research at the American Heart Association, which was exciting. But in the end, when you think about ACS-PE dissection, the testing is different for each of those, right? ACS could be, and this is my argument that I make when I start a lot of my lectures, the testing for ACS, troponin, EKG, plus minus, usually a chest x-ray, right? For a lower moderate risk PE, D-dimer. For a maybe moderate or high risk, you're concerned about it, dissection, CTA, right? Because the testing is different, we have to get some amount of data that tells us whether we should even be concerned about those things. I've done over 170 medical legal cases that I've looked at, mostly for defense, probably 3/4, about a quarter for the plaintiff. Haven't taken all of those cases, but those are the ones that I've been asked to review. Then obviously a lot are taken in reports and the depositions and eventually trial on some of them, right? But the short version is the biggest fallout that I see on those cases is not considering that differential. And I have a statement that I say, if it's not in the differential, it won't be in the diagnosis, which was actually quoted on the PIT, which was exciting. But the other thing is we talk about the history, and that history is free, right? Well, until you gather adequate data, how do you even know what testing to do for a chest pain patient? Because the testing is different, with each of those big three life-threatening, can't miss diagnoses with chest pain.
Mm-hmm. Yeah, I remember I had an attending that he was kind of an older attending, and he was one of these guys that says, don't write your differential down, because if you get sued, they're going to say, how did you rule this stuff out? And I remember the other doctors I talked, he was the only one that ever said that. And I remember that stood out to me, because I thought that's different from what everybody else is saying. And so I as I went through my training, I would ping each one of my other attendings and say, hey, do you write your differential on? They said, yeah, I do. And I said, well, I heard one time that, if you don't write it down, then, you don't have to defend why you didn't think of it. And they said, you need to do that on every case, no matter what. So you might as well write it down and make that as a checklist. One of them explained it almost like how pilots go through a checklist before they take off. He said, when you have a chest pain patient, you go through those big diagnoses and you rule those out. You don't always need a CTA to rule them out. You can rule out a lot of these with history or other things, but you better go through those and rule those out in your documentation, and more importantly, in your mind. And I thought that is interesting, because it was almost like this one was thinking, well, if I don't write it down, then I won't manifest it into being or something, kind of like, I don't even want to think about it, kind of a thing. But I found that to be poor judgment,
Yeah, and that differential is really important. I'm sorry, go ahead, Eric.
No, I was just gonna say, with your legal review cases, what you're like, I imagine you would be like, please put a differential. Like, that's going to be super helpful.
Yeah. So a couple of thoughts on the differential is, if you're doing it because you're a nice person and you want to be super nice to your coder, builder person, I'm not that nice of a guy. After you list 2 or 3 things on the differential, you can't bill more for like 10 things or 20 things or 30 things. That doesn't change it. You've already sort of satisfied that billing part of things. So if you have a differential that is something that you should consider at the completion of your evaluation, yeah, put that in there and why you don't think that's going on. But just mentioning something that you don't further explore in your history or exam or testing, that's where I think you could come into a problem. So, for example, aortic dissection, you could put that on your differential. You didn't ask one question about it. You didn't check one thing on your exam, and there's not tons of things on the exam for it, of course, right? Obviously you didn't do a CTA for it, but it's there. That's going to be difficult later because they're going to say, you mentioned it was on your differential. What did you do to rule it out? And it's then going to be incumbent on the physician to say about that. So one other thought on the differential, and this is another expression that I use commonly, is that a differential diagnosis is dynamic. It's not static. And what I mean by that is when you walk in a room, you have a certain differential. So say, for example, and we'll stay on the topic of chest pain, right? You have a 50-year-old person, 2 stents, they have chest pain. ACS PE dissection, maybe ACS is pretty high on that. Well, then you examine them and you see group vesicles with an erythematous base and a dermatomal distribution that doesn't cross the midline left anterior chest. Now your differential is different. It's zoster, which is pathopneumotic. That's the only thing that it can be. So that differential is different after you evaluate the patient compared to when you walk in the room. So to me, it feels like a differential at the completion of the evaluation is the more important differential to talk about. The other thing is, as far as billing goes, if you order troponin, the coders, from my understanding, know that you've considered ACS or whatever else could be ruled out with troponin, right? That they've considered that as part of it. So maybe that hard stop we talk about in the MDM, and a chest pain patient leaves, I don't think it's ACS because ABC. I don't think it's PE because of ABC, DE, whatever. I don't think it's dissection because of those. One thing I want to caution, this is the last thing on this point that I would say, is that it's not enough to say in your MDM, I considered but do not think this is ACS. Now, that might be enough for your coder, but if it turns out to be ACS and the patient dies, like Anna did, unfortunately, of an autopsy-proven MI with a big thrombus in the LAD, right? Well, you don't think it's ACS. Why? Why don't you think it's ACS? There's so many reasons I could sort of talk about, right? But say why you don't think it's those things. And again, that hard stop, maybe when you're doing it, you'd say, I can't convince myself. I can't convince someone else. I need to go back and get additional data gathering, history and physical, or additional testing.
Yeah, I love that. When I was leaving residency, I remember I mean, I think everybody's probably nervous when they're getting ready for their first shift.
Right.
And I was talking to one of my attendings, and I said, "Man, I'm a little stressing." And he goes, "Just do this. When you get ready to discharge a patient, present it to me in your head.
Mm-hmm.
And if you can't convince what you think is me, you don't be convinced yourself." And I think that's a great stop, is kind of like, okay, I don't think it's ACS. Like, well, I mean, awesome. But give me some reasons why. Like, give some background. And if it's not sounding convincing to yourself, then you need to either do a little digging or go in and talk to the patient again or something, because that doesn't make sense.
Yeah,
and there's easy things to do with that, right? You can, I mean, if you want testing wise, get a second troponin if you've only done one, and I often do one, or you can get a second EKG, or you could talk to family who has now arrived, or you could even confirm with the patient the symptoms. And I've had patients, they're like, well, my chest pain's intermittent. How long does it last? I ask them, 5 seconds, 5, 4, 3, 2, 1. Do you have any now? Yes. 5, 4, 3, 2, 1. Do you have any now? Yes. And I say, you told me it's intermittent, lasting 5 seconds. And they will say, and understandably, because they're the patient and we are the historian, documentarian, reporter, right? The patient will then say, well, my chest pain only lasts for 5 seconds, but this feeling of an elephant sitting on my chest has been constant for the last 1 hour. Again, that's on us, right? I'll sometimes say in my documentation, this is another really big teaching point for our discussion here, is I've confirmed with the patient twice that they had 3 hours or say 4 hours of constant chest pain. At no point has it completely resolved during this time span. Well, 3 hours is sort of that magic number where we would think that a high sensitivity times 1 troponin should be elevated if this is from ACS. So sometimes that keeps us honest. Sometimes it's just another way of confirming in our documentation that the history we got was actually accurate.
Mm-hmm.
Yeah, my since I don't trust myself, I created a list of differentials, that I'd carry around on some index cards. So like chest pain, here's abdominal pain, so, and I wouldn't verbatim put all of those in my differential, but I would look at them and be like, I just want the ticklers, for these things that I just want to just run through and make sure.
Yeah. If this comes back as an M&M, what's the diagnosis? What did I miss?
Yes, absolutely.
And yeah, because it's just like you feel bad when you miss something.
Yes.
And
Mhm.
It sucks to get sued. But I think more than that, like you don't want to be the guy that blew it for some poor patient. But so how do you, when you're talking to residents and so I think, like Joel said, you're first starting out in your emergency medicine career, or you've been sued and you've gone through that, and you've got that phase afterward where, well, holy cow, I'm going to check so much every time because I don't want to get burned again. What's that balance between good risk management without pushing into this defensive medicine, where you're, because that can be a tricky thing when you're unsure of yourself or you've had a bad outcome.
I end a lot of my lectures with the phrase that I realize some of this is scary, but in the end, the point that I'm trying to get across is that I don't want you to practice defensive medicine, but what I do want you to do is evaluate and document in a way that's defensible. And what I mean by that is, we have a lot of patients that are obvious, right? The corneal abrasion or the ankle sprain. And then some patients, which are higher risk, right? Chest pain, abdominal pain, headache, fever, and something, right? So when you think about those patients, maybe those are the ones we put a little extra documentation in, right? We can contemporaneously, and whatever EMR you're using, usually there's a part where you can put a narrative that date and timestamps it as you go through what you're considering, what you've done with that patient, right? So when you think of your average shift, and just to keep the numbers even, it's like a 10-hour shift, say you just see 2.5 patients an hour. So you're like 25 patients a shift, right? Well, you're going to admit 20 to 30%. I'm not saying those are no risk, but probably you're going to be okay on those. The other ones that you're sending home, most of those you're pretty confident on. There might only be 2, 3, 4, 5 patients per shift that there is some of that diagnostic uncertainty when they leave. Those are the ones that I would spend a little bit of extra time with. And the other part in answer to that question, and it's really, really important because look, it's a crazy profession that we're in, right? You couldn't imagine a high school teacher who gets sued 2 years later because someone's child doesn't get into the college of their choice, or someone who's training a dog who gets sued 3 years later because the dog bites the mail delivery person, right? I mean, that's insane to even consider that those types of things would happen, right? But it's a weird profession that we're in where we could be sued for doing our best. So thinking about not only our training, but also really knowing the literature. For example, the PERC rule, right? It doesn't 100% rule out PE, but based on the original study, 2004 Journal of Hemostasis and Thrombosis, it's 1.4%. And so, you go through, maybe it's 1 or 2%, whatever it might happen to be, but that's lower than the threshold of the risk from testing for it in a patient where it's not really indicated. In the end, knowing that data can make your life much, much easier. In fact, Jeff Klein, in a personal conversation I had with him, he said he's never had a legal case where the doctor considered PE and then it turned out to be a PE. It's always been like, oh my gosh, I can't believe this was a PE and the patient died from it. So as far as that consideration, and I remember when I was a medical student at Ohio State, they said, if you think about PE, test for it. And even as a lowly medical student, I'm like, that doesn't sound right to me. I wasn't the best medical student in the world, but I'm just saying that just didn't really sound right. In the end, we should always consider PE in every chest pain patient, but we can almost all the time very rapidly rule that out. And we gave the example of the walking in the room, ACS PE dissection, walking out of the room, zoster. So our differential is dynamic. We are considering PE, but maybe making some notation like you guys have talked about in the chart. This is why I don't think this diagnosis is going on, because they're PERC negative or for whatever other reason, or I have a viable alternative diagnosis, like they just got hit in the chest with a softball and they get facial wincing when I palpate the left lower sternal border. So yeah, it's a scary thing to think about, but in the end, and here's the statistics, is that 75% of doctors will be sued by the age of 55. That sounds scary on the surface. To me, it's like the other way. Like, really? By the time you've been practicing medicine for a quarter century, a quarter of doctors won't even be sued one time. And even of the ones that are sued, 2/3 are dropped or dismissed. So, plan on that happening at some point, probably if you see enough patients. But in the end, it's unlikely that anyone listening to this podcast will see the inside of a courtroom. That's an uncommon occurrence.
One thing that you said I think is really interesting. I remember I started a few years ago, well, it's been a number of years ago now, running through my rule out diagnosis criteria, PERC criteria, for example, with the patient. Or another one is like the Centaur, I know the Centaur criteria is kind of debated for strep throat, but you run through that with the patient, they love it because that's what they don't understand a troponin. They don't understand a T-wave mild abnormality on an EKG, but they do understand chest pain with exertion. They understand leg swelling and those kind of symptoms. Those are the things they're putting into Google and ChatGPT, right? That's what they get. And so if you go through and you say, I don't think you have a pulmonary embolism based on these things, and you go 1, 2, 3, 4, 5, and then you say, in fact, there's been a study about this that said that the chance of you having it is at 1% and these kind of things. They love that discussion because it brings them into the decision making of the physician, as opposed to you don't have a blood clot in your lung. Like I don't think you have one. Then that discussion they feel kind of dismissed, I think. You know what I mean? But are there certain ways that you found that you interact with patients that have been good? Like the way you mentioned, thank you for trusting us to come back. I wonder if there's certain things. That's one thing we're working on with our group right now is like how to interact with patients so they feel validated, feel heard, but also understand that when a physician is saying you're PERC negative or your heart score is 1 and I feel stable for you, like feels good for you to go home, it's not just a hip shot. It's not just that we didn't even think about it. It's like we went through this diagnostic process in our head and this is what we've come up with.
Yeah, and Scott Weingart oftentimes talks about it's not failure to diagnose, it's failure to consider. So you can say to a patient, and I think this is fine, I've considered this as a diagnosis. I think it's really, really unlikely. Pull up MD Calc and look at the PCARN criteria for your 18-month-old, and this will tell you the same thing that it tells me. Now, of course, I'm doing the exam and the talking and all that sort of thing, and I have context to that clinical decision rule that a patient might not necessarily have. But I love also, Joel, that you said you validate their concern. That's one of the really, really big things that will really piss a patient off is when they feel that they have wasted your time or you're making them feel like you wasted their time. I do sometimes scripting, and we all want to be these super awesome, creative, smart clinicians, right? That we're seeing all these patients. But in the end, sometimes saying that, look, I wanted to sit down and explain some of your test results. I'm glad you came in, but I have really good news that I don't think you have cancer for this reason. I don't think you have pneumonia for this reason, or ACSP dissection, or whatever it might happen to be. However, realize that we're never 100% in medicine. Symptoms progress, change, worsen. So if those things happen, this is a partnership. And when you go home, I want you to come back if one of those things occurs. Are you comfortable with that? And I had a patient, and this is a story that I told on MRAP, was a woman in her 40s and was set in to rule out PE. She had fallen off of a hammock. She had reproducible chest wall pain, was pleuritic, of course, and she had a negative chest x-ray. And she went home, talked to her primary care doctor, who said, I sent you in there to rule out PE. It wasn't ruled out. The test is what they meant. Sent her back. And I'm sitting like with my family, this like warm Ohio summer night, on the porch, whatever. I get this call from the department chair. It's like, this patient bounced back. Now, I will say this, that's a really bad idea as a department chair, because we talk about patient satisfaction, physician satisfaction, physician wellness, not a really great idea. But they called back and I said, okay, thanks for telling me, but this patient didn't have a PE. She fell out of a hammock, and that's when her pain started. And I get it that she had a DV2 when she was pregnant 20 years previous, but they did the test and she did not have a PE. Well, the interesting part, and the reason I'm telling the story, is that the patient was totally good with that when I talked to her. But you know who wasn't really that good with it? Is her husband, who was sitting with his arms crossed in the corner, scowling at us, and making sure that family is involved around a long-winded way of sort of bringing home this point, is making sure that not just the patient's comfortable with that approach and some of that small diagnostic uncertainty going home, but that the family or anybody else is comfortable with that also, is super, super important as far as avoiding some of those bounce backs, like when you're sitting on your porch on a warm Ohio evening. That's something that you never really want to have happen, but it can be pretty easily avoided. And sometimes I've said to patients, like, I'm talking to you, just your body language. You don't really, it doesn't really feel to me that you're convinced what I'm saying. And I totally get that. My job is to give you advice. I'm super happy to have you get some other advice. I'd be happy to call and talk to your primary care doctor. I mean, this is like, honestly, I sense this like, I don't know, like twice a year or something, but like you could avoid so much hassle and so much extra time with that department chair or with yourself, right? By addressing that up front. It's not a common thing, but with some of those techniques, sitting down, doing some scripting, making sure it's open and honest, validating the concerned role, like you said, can be big ways. The really, I would say that the biggest way that we can help ourselves is avoiding the malpractice action or the patient complaint in the first place, as opposed to being able to defend ourselves later on it. You never really want to get to the point. Greg Henry, I'll quote him as saying, in a medical malpractice action, there are two losers. There's one loser and a bigger loser. There's no winners.
Right.
Yeah.
Yeah,
absolutely.
Would it almost, the police have body cams. I almost want a discharge video cam. It's not video. I thought it'd be great to record all of my discharge instructions with patients and make that part of the medical record. And it'd be good if the patient could get it, because all the data showing it's like, you tell people this, but what you think you may be explaining it correctly, but they may, some of the words they don't understand, or they're not willing to tell you that they don't quite understand it. And there's so much going on that they only retain a small percentage of what we tell them at discharge. So I would look, and I've told patients sometimes to pull out your phone and record, like, let's record what I'm saying. So later, this is very important. You play it again,
That type of stuff is discoverable later. Like, they will ask patients, did you send texts to your family? Are there posts on Facebook of this patient? And we had a medical legal case, and this was really a tragic case of a patient. And the allegation was that they got to this ED and sat in the lobby for like 2 hours with their STEMI, gray and ashen and diaphoretic. And the defense pulled up, they subpoenaed the security camera footage. They parked at one side, walked all the way around the hospital, walked all the way through the hospital. And you can see the patient like doing all these things. They get to the ED and they were there for, I don't know, like maybe 12 minutes or 22 minutes. I mean, it's a very short period of time relative to what a patient, how long a patient could sit in the ED. I get it. You want to do an EKG within 10 minutes, but I'm just sort of saying that it wasn't 2 hours, that's for sure. And they weren't ashen and diaphoretic. So having the patient recorded can be something. That being said, it's the patient, they switch cell providers, they don't have access to that anymore. What I tell people, and I tell a lot of residents this as well as attendings too, is in your documentation, put in the medical decision making, I spoke with the patient and their family, and we discussed the possible diagnostic uncertainty. We think it's unlikely. They do understand and agree to return if their symptoms progress, change, worsen, blah, 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 right? And then even in the discharge instructions, another big teaching point of our discussion here today, to say something like in your discharge instructions, as we discussed, comma, return with, if your chest discomfort returns, or sweating or shortness of breath, or whatever you might want to put in there. And now you've said twice in your documentation that this conversation has occurred or had occurred. And it's really going to be the burden of proof on the plaintiff to show that you somehow fudged your records or that actually didn't happen. So I think we're probably pretty far from the body camera footage, but it's an interesting idea. I've had someone else suggest that also. But you can sort of reflect that in your documentation, what transpired at discharge and during the encounter.
I was
Yeah.
almost more interested in the patient. You know, worried that the patient was kind of, they're overwhelmed and not going to remember what we told them,
Right.
and I know some of those discharge instruction systems that people have, it's not super easy to personalize, or you're busy, and so there's just the standard print, because I think making something more personal in the discharge instructions is the primo standard, but so when I look around my colleagues, I don't see that happening very often.
Yeah. That brings up another question I wanted to ask you about AI and the role there in minimizing bounce back or risk stratification and that kind of thing. Do you see that starting to move into the field? I know every time I turn around, there's some new thing AI is doing, but I'm not seeing it too much yet in the clinical practice outside of, open evidence and these things where people are looking things up. But I wonder if that's a role to say, like, hey, put the brakes on for a minute. This is a high risk for bounce back potential here. Are you seeing anything like that in the field yet?
So I haven't seen any cases with AI scribe, and I know that wasn't exactly the question, but I exclusively used that for 2 months, and I found that it really wasn't capturing my thought process and my MDM the way I wanted it to. Now, there's people that like literally would divorce their spouse and marry an AI scribe if they could, because they love it so much. The data shows that it doesn't really significantly allow us to see tons more patients, maybe half a patient per week. This is in primary care. When you'd think that their notes are so much longer, the AI scribe would be even better for them. But as Sanjay and Mike have said on EMA, this is the worst it will ever be, right? It just keeps getting better and better and better. And so one comment that you guys were talking about earlier is, as far as going through a differential with the patient, that could be something that allows AI scribe to more accurately reflect the conversation. And it maybe also prompts us to have that conversation with the patient, which can lead to better patient satisfaction. And maybe they would think that there's more of a partnership if there is an adverse outcome or something is different than the way you discussed. As far as the AI open evidence, which I think is great. However, I will say, and I use that a lot for writing and research that I do. However, I always confirm that what open evidence says when they reference an article, that the article actually says what they're saying that it says. And I have to say that it's true like 80 or 90% of the time, but it's not 100% of the time. So it might be able to form a good differential, but think about this. A patient says, I'm short of breath. Well, is it really like can't sometimes take a deep breath? Or is it more that they have air hunger when they're at rest, or they find at rest and they have air hunger with exertion, right? So there's a lot of different meanings to certain words, or sudden versus gradual. And a big interest of mine is documentation. I was telling my resident this morning doing our EM didactics, I said, I had a case where I turned it down. It was a headache case. They didn't document the acuity of the onset of the headache. The patient the next day died of, I won't say exactly, but you could probably guess, a terrible thing that could have been potentially diagnosed if you had documented the acuity of the onset. Anyways, short version is that, it's good to say it was sudden or gradual onset of a headache. That's good. It's very good. That's certainly standard of care. But here's what's even better. The patient's headache started at noon and reached maximum intensity of 4 p.m. Now, that might be sudden onset to the patient in the context of their 65 years on this earth, right? However, to us, the three of us, that's a gradual onset of a headache, 4 hours. That does not make me concerned about something like a subarachnoid hemorrhage. So with our documentation, our data gathering, AI, I think, is going to be really good. And maybe if you have a diagnostic dilemma, that could be helpful to put something in. It's unclear whether saying that you put it in is something you should put in your chart. I would be reluctant to do that. Not because you want to be dishonest. You always want to be 100% honest. But what if open evidence says, oh, you should work this patient up for something that is not occurring? Well, then what are you going to do? Or maybe they could find the open evidence search that you did and say, hey, open evidence said you should have done this. And it was the 1 in 10,000 that actually turned out to be true. But anyways, the short version with all of this is the language that patients use is different, but that's part of what we're doing. We're interpreting that language as historians, right? We're not, another phrase I use all the time, we are not transcriptionists, we're historians. It's up to us to interpret the information they give us, and then how to incorporate that into a intelligent note that reflects the presentation that they gave us.
Yeah, that's
Do you
great.
have any, you've been chair of peer review and been involved in, all the kind of medical legal reviews. So
all the stuff.
So how do we, what pearls of wisdom do you have for being like, we want to be conscientious, we want to be investigating ourselves, we want constant improvement, we want to find mistakes and improve without, and you mentioned the physician wellness piece. So, I'm glad I didn't grow up in a surgery residency where they eat their young. They're much more collegial with our M&Ms and focused on, teaching points. So, what are some pearls of wisdom of navigating difficult or poor outcomes, misses, mistakes, in a way that's helpful and not entirely punitive?
So I'm going to paraphrase, and I will just have a little bit of a segment that both of my grandfathers were general surgeons. And I'm sure in the 40s and 50s when they trained, there was a lot of eating your young at those M&M conferences. Yeah. My father was an ophthalmologist, and so surgeon also, but probably less toxic than the general surgery residencies of the 40s and 50s. But at any rate, Pat Crosscarry, actually, that's not true. It was actually Weirs and Nemeth. They had a editorial that they wrote, and it was brilliant. And they talked about how you should conduct an M&M conference, how you look at these cases, because they said, what they said is, and I'm going to try to paraphrase this, we don't learn as much when we say, why did the way that you framed that problem, why did that turn out to be incorrect? You can learn some stuff, but what we learn from a lot better is when we flip it and we say, why did the behavior of the physician at the bedside when they saw the patient, why did it seem so reasonable to them at the time? And a lot of times, and I have this lecture that I do, maybe I talked about it already, called How to Spot the Well-Appearing Patient Who Will Soon Be Dead. And a lot of that is because the patient tells us their diagnosis, like we talked about earlier with Jonathan Larson with the bad turkey sandwich, or they stand up and shake our hand and are well-appearing, and their tests have come back fine, and we don't understand the limitation of a test. For example, like the case that you gave in the beginning, Eric, with neck fash, right? There's not a test that will rule out neck fash. That's a clinical diagnosis. And Alma and I gave a lecture when testing trumps history and when history trumps testing. And it was an interesting discussion of, what are your limitations for both of those aspects of data gathering, either history and physical, or with testing. So anyways, short version is to put yourself in the footsteps of that clinician at the time, maybe even to have some sort of blinded review that you do of that case without knowing the outcome. And to do that would be, I think, the fairest way that you could analyze the behavior and the actions that the physician took. But as far as understanding a way to change behavior and to make patients safer, it's sort of what Weirs and Nemeth said is, why did your behavior seem so reasonable? And then what can we do, maybe even using Pat Crosscarry's concept of metacognition, to then understand when our decision might be, when is to understand when our decision making might be prone to error, and then we can take steps to change that.
Thank you.
Any phraseology that you use with your residents to teach diagnostic humility?
You know what? After their first bad case, they sort of get it. But yeah, before that happens, what I do really in the first lecture that we give, we talked about chest pain, probably because I'm sort of interested in that, but also we talked about that actual case, the case of Anna. And what I do is I lead them through the history that this physician got. It's 7 lines, and it's 7 lines that have some past history, some extraneous stuff. But at the end of that, I asked them, I said, have we ruled out or satisfied ourselves that ACS, PE, or dissection are unlikely based on the data gathering. Would you be proud with this data gathering that you did? And maybe, as we talked about earlier, then having that resident understand, look, when you're discharging a patient, what could still be going on? Wake up dead kind of scenario, right? And then how have you addressed for that? Again, you don't want to be a bold pilot because you will not be an old pilot.
Exactly. Yeah. And Joel, you kind of comment on AI. I'm curious to see how things move in our lifetimes because things are moving fast. It sounds like it's doubling capabilities about every 7 months, right?
Uh-huh.
So that, I'm always worried, are we going to abjugate some things that we should be doing to, technology or testing, how do we stay, a good historian?
Uh-huh.
So I don't know if you have any thoughts kind of in your teaching realm, seeing all this kind of on the front lines.
Yeah, well, I do for sure. And in the end, it's very hard for AI to tell a 80-year-old that their spouse has died. It's hard for AI to do an emergent procedure. And even though AI might be able to form a differential, it's hard to balance the risk of testing versus the risk of missing a diagnosis. What is our acceptable miss rate? So for chest pain, ACEP in the 2018 clinical practice guidelines said that we have an acceptable miss rate for missed non-STEMI ACS of 1 or 2%. And they specifically say, and they're trying to get lower than that number, will cause harm from false positive testing. And that can go with so many things. The PCARN rule we've already talked about a little bit. I mean, if you pull up, you could do in Corpendium or out of MD Calc, but they will say with those patients that the risk of a radiation-induced malignancy is higher than the risk of not a head bleed, but neurosurgically amenable head bleed. So whether that can be factored into AI later, maybe not. I think just foregoing it completely, I think would be unwise because it is so powerful and so potentially helpful. But again, what we do with our practice-based learning, in other words, we're not in medical school for 7 years and then we start seeing patients. We're there for 2 years and then we start seeing patients for the second 2 years and then residency 3 or 4 years, whatever. But in the end, that time is so important for us. And the big word, and I've said it before, is context. That's what we're learning. That's what we learn with podcasts, right? We learn context. We don't ask every chest pain patient 50 questions, as might be in Tintinelli or Rosen's, right? We ask them questions based on the type of chest pain, their age, their risk factors, or maybe if we're doing the history and the exam at the same time, the fact that we have discovered something like a zoster rash.
I did admit a chest pain when I had an intern year. I did admit somebody for ACS when they examined him upstairs and found the zoster.
Guido Pence and I just did a whole intro last year on our UC Max podcast where we talked about our own misses with zoster. So you are not alone. I have done that also, without a doubt.
Yep. Guilty.
I was just glad
Yes,
I
guilty,
admitted
yes.
it rather than the other way around, where.
Right.
All right. Well, Dr. Weinstock, that's been fantastic. I appreciate the
Yeah.
insight. We're excited to hopefully get you out to talk to our group.
Love to.
This is like you said, somebody said, practicing emergency medicine is like sprinting through a minefield.
And a lot of times that sprinting is great. I mean, that serves us well. That fast thinking type approach serves us really well with the hypoxic on a non-rebreather or, BiPAP, COPD or CHF patient. That serves us really well with those patients. But, using that concept of metacognition, the highest level of thought making, as Crosscarry has said, to understand when our decision making might be prone to error is the thing that really is going to now allow us to pick out that needle in the haystack or that minefield, like you talked about, when it is the well-appearing patient, but they have unexplained tachycardia or a symptom that was put down in the triage note that we don't appreciate because we haven't read the triage note. or maybe even something that they would tell us that we don't understand is the gravity of it, or it's a bounce back patient that we don't take seriously.
Yeah, I just wanted to thank you really quick. I mean, I guess I'll speak on behalf of the entire field of emergency medicine, uh, but no, just your education parts about we don't get this in medical school about these cognitive traps that we can fall into, these biases that we can have without realizing it. But even further than that, the physician wellness piece. When we have one of these misses, which you say we're going to have some, it can feel very isolating and very alone, and you're kind of boxed in, and you don't want to reach out because you're embarrassed about what happened, and you of course look at all your colleagues and think none of them would ever have a problem, and I think it's just you've done good on the education, good for our field on the education point, but also on the wellness aspect. Bringing this to the forefront, understanding that we're not perfect, that we are going to have misses, and then using those misses not only to improve ourselves, but to be able to strengthen those around us. So I just want to thank you for that work. That's I feel like you've done twofold good for our community and for our patients by extension.
Well, it's an honor to be here talking with you guys. In all humbleness, thank you so much for saying that. It does mean a lot to me, actually. That but I've sort of devoted my time to has hopefully helped not only patients but also all of us in our profession.
Yeah, fantastic. And I'll have to get the new book when it comes out.
Yeah.
So when does it come out?
So we have actually we have 28 of the 30 chapters into the publisher. They're working on, the references, the PDFs, getting those designed. It's myself, Alma Matu, Kevin Clower. This book is peer reviewed. So the first of the books that's been peer reviewed first of this edition, the critical care one was by different critical care folks, but it should be available in the fall. I'd say probably late fall, honestly, but should be before the turn of the year, which is really exciting.
So not by ASAP, but after ASAP.
No, will not be by ASAP.
Okay. All right. That's what
It'd be nice, but exactly, yes.
All right. Well, thank you so much again. Really, really appreciate it.
Thank you.
Hopefully we see you in person in Phoenix coming up.
I'd love that. Thanks, guys. Good talking. Take care.
All right, thanks.
Thanks.
Bye-bye.